Welcome to It Starts Within, a podcast from Platinum Performance, where we'll dive into the health challenges faced by veterinarians and horse owners alike. Join us for inspiring stories about the latest advancements in equine care, treatments, and comebacks. You'll hear interviews with elite competitors, innovative researchers, and the veterinarians that devote their lives to horses and the humans that love them. At Platinum Performance, we know the power of nutrition starts within. Hello and welcome to the podcast, all. I'm Jessie Bengoa, and today we're here diving into yet another topic that affects horses, riders, and the veterinarians who serve them both. And this one delivers on the frustration factor, it delivers on the ick factor, and it throws in a very good dose of mandatory patience. And we're talking about strangles, ladies and gentlemen. This is an infectious bacterial disease that I'm telling you, once you've encountered it and had to deal with it, strangles will leave you hoping that you never have to see it again. But in the event that you do have to tangle with this one, I have with me today 3 veterinarians whose work has contributed greatly to what we know about this disease and also in how we handle it with maximum success. So let me introduce them, if you would. And first up, we've got Dr. Nicola Pasterla from the University of California at Davis. He's an equine veterinarian, board certified in both internal medicine and equine dentistry, in fact. And he is a professor of medicine and epidemiology at UC Davis. So welcome, Dr. Pasterla. Glad to have you here today, sir.
Thanks for having me too. Appreciate it.
And next up, we have Dr. Sally Donato, also an equine veterinarian, board certified in internal medicine. And Dr. Donato is a clinical associate professor at the University of Florida's College of Veterinary Medicine. So hello, Dr. Donato, and welcome to you.
Thanks for having me.
You bet. And rounding out our trio is Dr. Ashley Boyle. And like her 2 colleagues here, she's also an equine veterinarian and also board certified in internal medicine. And Dr. Boyle is a professor of medicine at the University of Pennsylvania's School of Veterinary Medicine, or the New Bolton Center. So hello there, Dr. Boyle, and thank you for being here, ma'am.
Thank you. Happy to be here.
I'm so happy you 3 are here, and we've definitely got the 3 experts in the room to talk about this condition. And there you have it. So a 1, 2, 3 punch, and we're going to get right into this disease. And they're here to school us on the ins and outs of strangles, or more correctly known as Streptococcus equi, subspecies equi. And I'm really eager to learn alongside the 3 of you. So let's turn you loose, shall we? And I'm going to start with Dr. Boyle. We're going to come to you first. And you co-authored, if I'm correct, ACVIM's consensus statement on strangles. So for those of you not familiar, that's the American College of Veterinary Internal Medicine. And I'd love for you to kind of kick us off with, I think, a good place to start, which is, what is strangles? If you would break it down for us and let us know what we're dealing with here. You know, what are the ins and outs of this condition, excuse me. It's very infectious. It's very contagious. It's a bacterial disease, sometimes a very yuck disease. And that's a medical term, folks. What's happening inside the body and where when strangles is contracted, as it incubates, and when it presents? Give us the down low on this.
Yeah. So it's contracted from close contact with other horses, or with fomites, or things that actually have the bacteria, the Streptococcus equi, subspecies equi, which we'll probably say from now on strep equi to simplify things, and it infects the pharyngeal lymph nodes, so in the back of the throat, and proceeds to go into the lymph nodes in the head and neck region. So in particular, the retropharyngeal lymph nodes and the submandibular lymph nodes. So the retropharyngeal lymph nodes are behind the mandible, or just at the throat area, and then the submandibular lymph nodes are under the jaw, and so basically it's an upper respiratory condition that results in or can result in nasal discharge, a high fever, and these swollen lymph nodes. But you don't have to have all the things to actually have the disease. So it can be a variety of presentations. And the I mean, I often describe it to clients as the strep throat of horses. It's caused by a different bacteria than what causes strep throat in humans, but there actually are some similarities.
Excellent. And, strangles, correct me if I'm wrong, it is rarely a fatal condition, but it can cause pneumonia and it can cause some greater problems when it presents. And it's sort of a spectrum in terms of how horses present with this condition. And it definitely, like I said, it's one that requires a lot of patience to deal with, doesn't it?
Yes. So normally it's upper respiratory, but you can have horses that are more affected by the disease and develop pneumonia. So that means that it's actually going into the lungs. Probably more commonly, it's actually when they've actually aspirated the discharge from the upper respiratory tract that results in pneumonia. So more commonly it is in the upper respiratory tract. And the other place that it likes to hide is the guttural pouch, which is an outpouching of the eustachian tube. And the way it usually gets in there is through the retropharyngeal lymph nodes erupting into the guttural pouch, and it can actually hide in there for quite a period of time. So, and then it can also manifest as a more serious condition, like you mentioned, as aspirating and becoming pneumonia, but or it can actually spread throughout the body to other parts of the body, which we call metastatic strangles or bastard strangles, where they actually develop abscesses in other parts of the body, which most commonly can be in the lymph nodes associated with the GI tract.
We're talking erupting lymph nodes and abscesses. This is such a breakfast podcast, y'all. Buckle up. Thank you for that. And Dr. Donata, I want to turn to you next as someone who's worked pretty extensively in biosecurity. So, talk to me about transmission. So, this is a very contagious disease, and left unchecked, I mean, it can spread through barns like wildfire. So, how is it transmitted from horse to horse, and what's happening at the different stages of this disease that make it particularly contagious? Meaning, as a horse is asymptomatic, when it starts to present symptoms, and as it's being treated and it starts to heal. So risk can linger, correct? Give us the details on that.
Yeah, correct. Yeah, Strangles is the gift one horse gives to the other, sadly. And there's three main scenarios in which this happens. The first one being through direct contact with the nasal discharge or pus that results as a consequence of infection. And so this is a pretty straightforward mechanism. You have one sick horse in the throes of active infection. He's got nasal discharge or actively draining abscesses, usually retropharyngeal or submandibular. And another horse comes along and sniffs him or comes into contact with him and gets infected via that route. The next direct horse-to-horse transmission scenario is actually a little bit more, it's a little trickier, a little more sinister. It's through an asymptomatic carrier. And as Dr. Boyle mentioned, we know that some horses for reasons that are not totally understood, can harbor Strep equi infection in their guttural pouches chronically. And these are the typhoid Marys of the strangle situation. So they can have active, um, viable live bacteria in their guttural pouches for long periods of time. They can have pus in the pouches or chondroids, which are actually sort of dried, inspissated, chronic accumulations, concretions of pus. And those are just full of active replicating bacteria. And those horses may have no clinical signs at all, but periodically can have low grade fevers and have nasal discharge. And during those periods of shedding, they can act as potential sources of infection to other horses. And so those are the scary ones, because those are the horses that you hear about. Perhaps someone gets a horse from an unknown source or location, or a sale is kind of the classic, especially here in the South, in Florida, where I am. The sale horses have a high propensity for having somebody with strangles in the population at a horse sale where they're commingling. And if the horse hasn't had any clinical signs, then people may not recognize the risk, introduces that horse to a new barn that has not been exposed to strangles in the past, and then that horse precipitates an outbreak without anybody having really understood what was happening or where that infection was coming from. And then the third scenario is through indirect contact through fomites or people. The bacteria Strep equi doesn't exist terribly well in the environment, especially not sunlight is pretty good at deactivating it, killing it within 24 hours. But in the right, cool, moist conditions, I think it's been shown to survive up to potentially 6 weeks. And it's pretty tenacious. Like when you think about kind of a snotty nose, it can get on nose rags, on grooming supplies, on tack, on clothes, on hands. And one person moving between horses can go from an infected horse and spread it very efficiently to a naive horse.
Wow. I mean, there's a lot to unpack there, because 6 weeks for the bacteria to live in a cool stall environment is a little scary in and of itself. And then those asymptomatic carriers that might have high enough immunity on their own, but they're spreading it without anybody really knowing is always a little bit scary. And correct me if I'm wrong, but the difference, a lot of the time pigeon fever and strangles get compared to one another a little bit, but strangles does not actually live, in the dirt of a stall or a paddock as pigeon fever would, correct?
Correct. Yeah, it's really not considered an environmental pathogen. I know sort of when I was growing up, everybody used to consider it that we would call them strangles barns, and they were barns that people thought had strangles in the wood or in the paddocks. But I think we now recognize that it probably wasn't in those environments or those facilities. It was in an asymptomatic carrier. And had someone gone through and scoped the pouches on every horse on the property, which sometimes is how we now have to address these farms with recurrent strangles cases, and you find that typhoid Mary that does have chondroids or pus accumulation or a positive sample from the guttural pouches, and by clearing up that single long-term asymptomatic carrier case, you can solve the long-term strangles problem on the property.
They are not the forever contagion barn, so don't judge.
Yeah.
Okay, got it. All right, perfect. Well, thank you for that. And Dr. Quisterler, I want to come to you next, and focus more on the surveillance, the monitoring, the screening, the testing. And that's something that Dr. Donata just sort of mentioned. But that's going on with these cases. So you've done a lot of work in this area. So talk us through that, would you, sir? What are the best practices? How would you recommend handling this aspect of an affected barn?
Can I take a detour?
You can take anything you want. You go for it. Yes.
That's fantastic. So first of all, I really appreciate what Sally and Ashla said. It is, amongst all respiratory pathogens, really the one that gives you a headache. And as I always say, I take any viral disease outbreak over any strangles outbreak, just because of the longevity. Once it's there to stay, and it's there to persist for quite some time. Well, some of the observation that I think are relevant, that I had to either accept or maybe I even made them up. So I'm not quite sure. But we are part of the biosurveillance program. And so what we do is on a monthly basis, we collect information from horses with acute onset of fever and respiratory signs, which really apply to a variety of respiratory infectious diseases. We're talking about flu, herpes 1, herpes 4, rhinitis virus A and B, as well as strep equi. And I'm using this just to look at, you were talking about epidemiology, how the face of strep equi has changed. And I'm just going to use the term in the last decade, but it may even have started earlier. If we look at the distribution of common respiratory pathogen as they affect horses, and I'm looking at horses of all ages. So think about, 100 horses that present to a veterinarian with fever and respiratory signs. So that could be nasal discharge, that could be coughing, that could be mandibular lymphadenopathy, increased respiratory rate, you just name it. In the past, we had respiratory virus leading this group, mostly equine herpes virus 4 and equine influenza virus. It kind of makes sense. They affect young horses. There is a seasonality to it during the colder month of the year. So these are the two pathogens that comprise the majority of these cases. Well, what we've seen in the past decade is that strep equi has become the predominant respiratory pathogen. And two other observations. One is it affects all age groups rather than saying it's predominantly in young stocks. And the other aspect is it's detected year round, while the others are generally associated with colder month of the year. It kind of makes sense. There's more young animal on the ground, the amplifiers, like kids going to daycare, and the husbandry is slightly different. So I've tried to answer this question. I'm glad I have two world experts here, because I'm quick at justifying an observation, and maybe it's just an observation, but I believe one of the reasons why we see increased cases of strep equi in all ages year around, it's because we do a very poor job at eliminating silent carrier. We live with it, and that's a fact. Why? It's because it's cumbersome. Nobody likes to do it. It's cumbersome, costs some money, and so we just live with it. And it's kind of sad because, with I would say proper protocols and maybe some encouragement and maybe looking at alternative techniques to, chase the silent carrier, we should be able to reduce the rate. And that's, maybe it's not a problem. I don't know. I mean, to me, it's job security. Am I right? I'm a veterinarian. It's like, yeah, keep on spreading it. You call me, I'll take care of it. But there's something in me that says, boy, we can do better. We ought to do better. So to answer your question, so what was the question again? No, I'm just kidding. So we're looking at the diagnostic part, and that's a big sticky part. So if you look at strep equi, every single aspect is sticky, and you have probably as many opinions as people as you ask. And there's a consensus statement, which is a wonderful document that Dr. Ashley Ball has led, and I wish they would update it. Now, I gave you just a headache, Ashley. You're saying, I know I got to do it. I just don't want to do it, but I got to do it. But it's a wonderful document that really brings together the experience for many experts in this field and gives us guidelines. But even amongst these guidelines, we can still debate. There is many aspects of this disease that we just don't know. As Dr. Donata said, we just don't know. There's certain things we just don't know. And so maybe we need to put more research into it. And the same applies to the diagnostic. So I like diagnostic for many aspects, mostly from an epidemiological standpoint. So we can look at animals, what they shed, where the organism is, and so on. but we can also use it for diagnostic purposes and trying to improve. So when it comes to Strep equi, we generally say, if you can detect the organism in an animal that has clinical signs compatible with Strangles, that's a very strong association. Now, what we have to understand too is that disease expression. We all remember COVID-19, SARS-CoV-2, and we all know that not every human that gets it will express it in the same fashion. But it's very similar for Strep equi. While we, if you look at the textbook, there's these beautiful cases with, upper respiratory catarrh, you got lymph nodes big as a baseball. I mean, even a blind person will figure out that this is Strangles. The reality is, if we look at older horses that have previously either experienced on the natural condition, the infection, or have been vaccinated, disease expression is different, is milder. And you're chasing something at places that is not there anymore. And then your typical example is the horse was febrile, maybe a little bit of snotty nose, nasal swab was collected, maybe it was submitted for culture, PCR was negative. And then 10 days later, the horse has a big swollen lymph node that drains, and they do a culture, and they culture Strep equi. And you're like, what is going on? So that's a little bit of the confusing part. But I'm going to circle back. I promise you, I want to answer your question at some point. So diagnostics. When it comes to diagnostic, that's an upper respiratory pathogen. Hence, we will detect in upper respiratory tract. The sensitivity, meaning the accuracy of the detection, depends a lot on disease stage. Biological sample collected, the deeper, the better. I'm going to explain that. The deeper within the respiratory apparatus, which means that a rostral nasal secretion collected with a 6-inch swab are not as sensitive, as accurate in detecting Strep equi than deeper biological sample that are collected at the level of the nasopharynx, and that could be a swab or a wash that gets a little bit messy there. And even better than that is a good old pouch lavage. That is still considered the gold standard, and I'm not going to question it. I'm going to get a dirty look from Dr. Boyle, but even there, is that a gold standard? It's time.
I think it depends on when. It depends on when they are presenting with the disease, I think.
Exactly, and I think that's the difficulty. So you have people don't like options. Am I right? It's like you go to the store and I just want strawberries. I don't know which size, which color, where from, which brand. It's too complicated. Just give me one. The difficulty with Strep equi is you have too many options. But to make it relatively simple, in a clinically affected horse, a horse that presents a typical clinical presentation, the early stages of disease of the horse's fever and nasal discharge, maybe a lymphadenopathy, nasal secretions in the majority of cases will be an adequate biological sample to collect. And it can be tested through two ways, either through culture, that's the conventional old-fashioned way. If you can culture, it's present, it's replicating, it's expanding, it's there. However, culture has its drawback. It can give you false negative results, mainly if there is an overgrowth with other strep organisms that are not Strep equi, if the horse has been on antimicrobials, or if they are biological inhibitors. This is why we have moved, the diagnostic field has moved towards PCR, polymerase chain reaction, which is the detection of specific target genes. So it's like the key in the keyhole, but it doesn't tell you if the organism is viable, which culture does, but it's way more sensitive, which means that we get more positive Strep equi cases using PCR than we do using culture. And the big question is always, well, what do we do with a culture positive, PCR negative result? That was kind of a question. What do we do with that? And so you ask the expert, and I'll say probably different opinions. Am I right? Some will say, well, Strep equi is there. I don't care which color it has. It's there. I mean, if this was EHV1, we wouldn't be saying like, well, is it viable? Not. We would all be running around like chicken without a head. So that's one of the issues that we have. And so what we are doing with these cases, the way I look at it, Strep equi, if detected through PCR, which does not necessarily indicate viability, is to me a concern, especially if the horse has clinical signs, which means that at least isolate the horse and repeat the testing later on. 2 tests are better than 1, 3 better than 2, and we can keep on going this way. So there is power in repeating testing. Most veterinarians, they look at testing and it's black or white. If it's negative, I don't worry about it. If it's positive, yeah, I'm going to start worrying about it. Well, things change over time. As I said, the biological sample is one of the factors that influence the result, as well as the testing platform. Now, we have in the past few years, and Dr. Ball has worked on that as well, looked at surrogate for viability. It would be nice to say, well, here's a positive result by PCR, but don't worry about it, because what we're detecting is only DNA of organism viable versus, look, you got small numbers, but that bacterial organism is viable. So you got to be very careful. And there are molecular proxy there that help us these days differentiate if this is a horse with likely potential for contagiousness versus not. So I just talked about the clinically affected case. Now we have the silent carrier. How do you detect the silent carrier? And that becomes cumbersome. And I think that's one of the reasons why we see, we're just leaving these typhoid Marys in the environment. We don't screen. And so screening is essential. And I think the key element is repeating multiple samples. So the key is really in repeating multiple samples. And we know that in order to detect these cases, so the typical scenario would be you have an outbreak at a boarding facility, you have some horses developing clinical disease, and then 6 weeks down the road, you want to screen these horses. You want to try to figure out which one is a silent carrier, because silent carrier will intermittently shed Strep equi, contaminate the environment, being a source for infection to other horses. So it's very important to capture these horses, to identify these horses, and to eliminate the organism in their glottal pouch. Generally, it's in the glottal pouches, sometimes somewhere paranasal sinuses, but generally it's the glottal pouches. And so, the gold standard would be glottal pouch lavage or multiple nasal pharyngeal washes. Now, if you want me to shut up here, I will, but I can keep on going here because there's some very interesting ways to maximize the diagnostic and saving money. And I'm big into saving money. Do you want me to continue?
I'd say keep rolling.
All right, keep rolling. All right. So people always say like, well, okay, glottal pouch lavage. I don't have a scope. I don't know how to do that. It's cumbersome. I would say if you suspect that you have a carrier, the inspection, the visual assessment of glottal pouches is a must. Has to be done because, if there's purulent material, if they're chondrite, inspissated pus, it needs to be flushed out. It needs to be treated. But initially, you got to screen these horses. So how do you screen these horses? If a glottal pouch lavage is not feasible, then people can do a nasopharyngeal wash. I'm not going to go into detail how to do that. But because we're using PCR, the key is, and that's something that the consensus statement has come up with, is we do 3 of these procedures sometime apart. It says 1 week. Nobody says that it has to be 1 week. It can be 1 day. It can be a week. It can be a month. It just needs to be spaced because of the intermittent shed. So if you look at salmonella, I'm not going to talk much about salmonella. If you're trying to eliminate a shedder, we're not taking only one sample. We take multiple samples time apart. Generally 1 day, could be 12 hours, can be just one fecal pile apart. So the idea is you collect the biological sample in a nasopharyngeal wash. Instead of submitting it to the lab, paying the shipping cost, paying the testing, you just hold on, put it in the fridge. Go back a few days later, collect the second sample. Go back a few days later, collect the third sample. So if you can collect 3 that way, feasible. Then you pull the 3 sample and submit 1 sample, 1 shipment to the lab. If the test is negative, great. You got 3 samples, negative. If it's positive, I honestly don't care which one was positive. I know that I need to with this case. I need to scope this horse. Okay. So here's something else that nobody really has looked at. Even nasopharyngeal washes are cumbersome to do. Some horses need to be sedated. It generally requires the veterinarians to do that. It's nothing that an owner can really do. But here's ways that potentially we would improve the testing. So what if, and I'm putting out the data, okay? So I'm going to deny that I was on this podcast if I'm wrong, okay? I was never here today. I was playing somewhere else. But what if we ask an owner to collect multiple nasal swabs and pool them together? How many? I don't know. I'm just putting out 5, 6, 10. Okay? And then you have 10 or 5, and then you submit that as 1 sample. And you test that. And if it's negative, what's the likelihood of this horse not being a silent shedder? If it's positive, then we know this horse is a silent shedder. And I don't have the data, okay? So don't stone me. The other aspect is, think about horses. Most of the horses spend 99% of their time in the environment, in their stall. If they are shedding intermittently, you will find it in your environment. And we've done quite a little bit of work in environmental testing as a proxy for the shedding status over time. So what if you swab a stall, you swab whatever, the feeding trough, the area where the horse has a lot of nose-to-wall interaction, and test that sample. If it's negative, it is very unlikely that the horse has been shedding strep equi, or is still shedding strep equi. If it's positive, that would require a follow-up upper airway endoscopy. So these are just ideas. Am I right? The idea and concept. I'm not sure. I may be full of it. But I feel like we need to change the dogma, even if we have alternative ways that may be easier to collect sample, may require more sample, may require a slightly different approach, but clients can do that in this situation. We may have a greater compliance at eliminating these horses.
My goodness. I don't even know how to start to unpack that. That was amazing. I'm glad you kept rolling, by the way. So thank you for that. Yeah, I mean, we keep going back to these silent carriers too. And I mean, you just walked us through the monitoring, the screening, how we can improve and get better, which we always can. And the silent carriers are so scary because, unless we are diligently monitoring these barns, they do get missed. And Dr. Boyle, I want to kind of come to you on that as well. Talk to me about what needs to be taken into consideration with Strangles. What are you paying attention to? What are you advising on at the different stages of this disease? Because there's a lot of questions with this one, as we just learned. And I feel like there's also a lot of debate. So there's the silent carriers. There's the controversy over antibiotics versus no antibiotics. I'd love to get your thoughts on that. Do we lance these abscesses? We need to be careful to not lance them too early. How do we handle that? Should we vaccinate as a preventive or only when there's an outbreak? I mean, there's a lot of different factors here that obviously riders should be working with their veterinarians on. But talk to me about some of these debates inside of Strangles and the best practices on how to handle this. And I'm sure Dr. Donato and Dr. Priscilla are probably going to have some thoughts on that too. But school us a little bit, would you?
Yeah. So, you had a lot of questions in there. So, following up on Dr. Priscilla's comments, there's been a couple of papers that have looked at rostral nasal swabs, and he's right about having multiple samples. A group in Sweden did a study looking at multiple samples. You definitely get more results that way. And so they found that if they actually even did the rostral swabs frequently, they didn't cool them, but if they did rostral nasal swabs, they could pick it up better if they did more samples. We did a study where we looked at for looking for carriers, or let me back up for a second. So that study in Sweden was in horses that were in the acute phase. So, I think it's still definitely up for debate as to whether a rostral swab can get a carrier, because we looked at 4 carriers with rostral swabs. We looked with a nasal pharyngeal swab, and then a nasal pharyngeal lavage, and then a guttural pouch. And we were able to find it in the nasal pharyngeal lavage and the guttural pouch, and didn't always pick it up on the swabs. And this was even with, there are different kinds of swabs out there. So even with ones that are supposed to pick up the bacteria or the sample better, we weren't able to actually pick up the carriers that way. So, but I completely agree that the horse that is in the acute phase, that has secretions and filament disease, you can find it with a swab. So, as far as lancing, so I think it is very important to actually open these swellings that are that are ready to be opened. So you don't actually want to lance an abscess that's really deep if it's too deep, because you actually can end up with like a secondary bacterial infection or cellulitis surrounding that area. So we usually try to get them to come to a head by hot packing or putting substances on the abscesses to actually get them to come more to a head. But sometimes you actually have to find them with ultrasound as well, but we try not to use our ultrasounds on Strangles cases so that we don't contaminate the equipment. But so you have to give them time to come to close to the skin to lance them, and sometimes that can backfire. So sometimes, I mean, I once had a case where we were waiting for that, and the horse actually ended up getting swelling in its head. And so we actually did have to, ultrasound it, find the abscesses and open them maybe a little earlier than we would have, because the horse was having a complication from the abscesses that were there. And that kind of leads into when would you use antibiotics? So an important thing is not to, we recommend, like in the consensus statement, we recommend using antibiotics in horses that are having complications. And that can be quite a variety of horses. So that can be a horse that is febrile for many days and is you're having trouble controlling those fevers with nonsteroidals like Banamine or phenylbutazone, and this horse is not eating or drinking because of these fevers and the way it's feeling it. I'm sure he has a sore throat. We don't know that for a fact, but I'm sure they do. And so if you're going on day 5 of that, you may actually want to consider using antibiotics. But the disadvantage of using the antibiotics too early is if you have not lanced the abscess or opened up or let the abscesses come to a head, then you actually will probably just prolong the whole process by putting them on antibiotics. Other times that we use antibiotics are very often the situation of the bastard strangle. So when they have like an internal abscess later on, these horses will often either have disease or maybe not have disease, but have been in an outbreak. And then, a month or two down the road, they have a fever, and you have to go on a hunt to find where that fever is coming from. And you find out that it is actually coming from an abscess that is in the abdominal cavity, and your veterinarian finds that out. And so and those horses actually do need antibiotics, because very often we can't access where that abscess is to drain it, because, for example, it's in the abdominal cavity. So those horses actually often need antibiotics for quite some time. I believe actually Nicola did the study where looking at the fact that they need antibiotics for usually a mean of at least a month to get those under control. So, and then sometimes we also have scenarios where they have hyperreactivity to the disease, where their immune system goes crazy, and that is purpura hemorrhagica, secondary to strep equi. And it can be in a scenario where either they are exposed to either possibly the vaccine when they already have an hyperexcitable immune system that is already primed for the disease, and or it can also happen in the face of an outbreak. So it may be like the second time that the horse has seen it. You may not know that it's the second time that the horse has seen it, but the immune system is basically primed to react as an overreaction. And so that leads, and so sometimes we will use antibiotics in that situation, but they also need steroids usually to calm that immune system down. And and again, if I'm going too long, I'm happy to stop. But there's lots of questions, things.
No, you're not going too long. I asked you 3 huge questions in one question, but and luckily that is a rare complication, right? I mean, it's a serious,
Yes.
but it's much more rare, which is nice, that we don't have to necessarily worry extensively about that, but it does happen occasionally. But yeah, the antibiotic debate is a really interesting one, because, when I looked into this further at first, it reminded me of fevers in children, right? As it's like, treat the symptoms, not the fever. That's the body doing its work. And that there's a lot of debate, about antibiotics versus not, because do they mount the correct immune response if they're given antibiotics too early, and so on. So no, I love what you're saying about that. It's really important information to know. And I think the vaccine part of it, there's a lot of misconception around that too, with intramuscular versus intranasal, and when should I be giving that? And, because it's not part of the AEP core recommendations, correct?
The vaccine. Oh, as far as the vaccine core. Yeah,
Mhm.
correct.
Okay.
Yeah.
What are your thoughts on that?
Well, so I think that, I mean, as I mentioned before, there is the potential that a horse can have an overreaction to the vaccine at times. So Dr. Timoney originally looked at this, and he recommended a titer to be checked prior to vaccination. And then we looked at this further. We looked further into this, and to like kind of figure out which number is the correct titer number to like is it safe to vaccinate and not to vaccinate? And this is an SEM titer. So there's a couple different titer tests out there. The one that's available in the United States is the SEM titer, and so that's looking at the reaction to a protein that is on the surface of the bacteria, and the SEM titer run and that's actually what the hypersensitivity is actually to is to the SEM protein as well. So currently the vaccines that we have available in the US are SEM based. Both of them are, and so that's where the concern about having the reaction to the vaccine is, and so usually it's recommended to do a titer prior to doing the vaccination, and I would say that it's also not recommended to vaccinate in the face of an outbreak, because of this risk of a hypersensitivity or purpura hemorrhagica. But there are new vaccines that are coming on the market in Europe. They're actually on the market that are not SEM based, and they are actually using those vaccines now in the face of outbreaks. But I think it's important to make the distinction that these are different types of vaccines. So until we have that one in the US, I would not recommend that we vaccinate in the face of an outbreak.
Interesting. Absolutely. Well, no, thank you for answering my very multi-pronged question. I appreciate that. And that was excellent information. And Dr. Donata, I want to move back to you because we've mentioned biosecurity on a little bit of a surface level, but I want to come to you on this.
The B word.
The B word, right? And dig a little bit deeper. Because this disease is actually relatively easy to manage in the patient. And I use the term easily, I guess, with air quotes, but it's often the people that are a little bit harder to control here, right? In most cases, I guess that's true. So talk to us about biosecurity and your recommendations for managing strangles in a barn, boarding farm, a ranch, whatever setting that you're in where there are other horses around and the worry for disease spread is high with this one. So what do we do? What are best practices? How are we the most responsible riders and caregivers we can be to not spread this thing?
Yeah, I mean, managing an active strangles outbreak or even an isolated case it's challenging. It takes diligence and work, and it requires horses to not move on or off the property, sometimes for weeks at a time. All of which are reasons for people to not enjoy having strangles on their facilities. And so I think it's important that we do that to prevent spread so that one infected barn doesn't turn into multiple infected barns. But to Dr. Pasterla's point earlier about what we really probably need to do is double down on trying to identify and eliminate these asymptomatic carriers that are responsible for keeping this pathogen alive and well in our populations in all states. But to your question, if an individual case is identified on a particular facility, then we were just chatting about this before we started the recording, that this is a reportable disease in all 50 states, which means that if your veterinarian or the lab get a positive result on one of the testing platforms that Dr. Pasterla mentioned, they will report it to the state veterinary authority. And then it depends by state whether or not the state veterinarians, which can be, they have local teams of veterinary support personnel all the way up to the state vet, how involved they may get in the mitigation and management process. So, and that may go from they're going to mark that the case was recorded and they'll let it be handled entirely by the farm veterinarian that did the original diagnostics, all the way up to in states where it's fully reportable, they're going to actually deploy a local regulatory veterinarian who will help manage the outbreak mitigation process. And usually that involves quarantining the facility, so shutting down any horses coming on or off the premises itself. And of course, that the goal of that is obvious, to not let it off the property and not let any hopefully unexposed horses come onto the property to get exposed. And then the second prong, so it's kind of a two-prong approach. You want to make sure the infection doesn't spread to other premises via quarantine. And then you want to make sure that you try to minimize spread within the facility itself. And that will involve, in general, we recommend that horses on a specific facility get separated and categorized into 3 groups, and we like to color code them. I think Dr. Boyle introduced this in her consensus statement that we have all followed for years now. And we break them into groups that are green, yellow, and red, with green being horses that have no clinical signs and no known exposure, direct or indirect, to the case at hand. And those horses are housed and quarantined somewhere separately on the facility. And then the yellow or the amber horse group would be horses that have no clinical signs, so they are seemingly healthy, but we know may have been exposed either directly or indirectly through fomites or handling. They have some conceivable way that perhaps they could have been exposed, and they're going to be in a group. And then we have the red cases, which are cases that are actively infected, and they're going to be in their own group, and where they will go through the course of their infection with or without specific, supportive care treatments, and management. As Dr. Boyle mentioned, a lot of these cases are handled by just supportive care for treating the symptoms. So perhaps anti-inflammatories, things to make them more comfortable, to make their appetites improve, but not necessarily using antimicrobials, which could potentially prolong the course of the disease. And so that red group is going to be in isolation by themselves. And then from there, the monitoring of the groups is important. Clearly, you have the reds, that they are infected, but the yellow horses are ones where you're really kind of you're watching them. Are they going to spike a fever, which is usually the first sign of a Strangles infection? And you have this nice little window where some of the work by Dr. Boyle and Pasterla in past years have shown that you can catch these horses when they first become febrile, but before they're actually shedding the bacteria nasally. And there's this great little opportunity to get those horses that spike fevers isolated before they start shedding and potentially treated. That is a window where we might actually treat with an antimicrobial and stop infection, hopefully, before the horses develop fulminant strangles with abscesses and guttural pouch disease. But the yellow group they're your high risk, so you're monitoring temps twice a day, looking for clinical signs. And then the green horses, the group that you think have no exposure, they're also being monitored with temperature checks and visual inspection twice a day. To your point about the people being the most difficult component, that is certainly true. And if you think about a big barn facility, it's usually a handful of people taking care of the entire population of horses. So in a perfect world, you'd have different staff taking care of each of the groups, but that's rarely, if ever, feasible. And so if you're dealing with a team of people handling all of the horses on a quarantined facility, then you can at least go about it intentionally, where people are dealing with the green horses first, then the yellow horses, then the red horses. And then certainly after handling any horses with known infection, showering, changing clothing, just your typical biosecurity measures that you would use for any infectious pathogen. Certainly no sharing of equipment between groups. It really takes, it turns routine, fairly streamlined barn operations into an all-day rigmarole on barns that are trying to prevent Strangles spread within their population. But it's certainly worth it when you think about the time and just the negative health toll of a horse having to deal with a Strangles infection. It can be prolonged. They can be out of work, out of show, out of competition for weeks and weeks at a time. The abscesses can be slow to develop, slow to to mature and drain, and horses can be infected for up to 6 weeks. So it's worth the effort. The other thing I just wanted to comment on briefly, in line with what Dr. Pasterla was saying, as far as the various diagnostics that we have, we're lucky in that the diagnostics that we have, particularly the PCR assay, it's a really good test. I mean, it is rarely wrong in its accuracy. It's very sensitive and very specific, but the efficacy of an assay is only as good as the sample that you apply it to. And so we get a lot of questions about retesting. I think I just consulted on a case just this morning, a horse that looks like Strangles, it walks like Strangles, it smells like Strangles. I don't know if it tastes like Strangles. I didn't ask the vet that, but sure enough, they swabbed it, an abscess and potentially an abscess and then nasal swab, and they got a negative PCR, and they wanted to know, do we release this horse and open this barn? And my answer was no, because I wasn't there to see that sample taken. I don't know what happened to it. I don't know. I trust the PCR test, but not necessarily the sample. And so the recommendation was to test again. And certainly that's, I think, an important thing for horse owners to understand, because it's frustrating. You do a test, it comes back negative. So let my horse go, please. And really, we're just trying to be err on the side of caution, recognizing that these are biologic samples that there's plenty of places for error and imperfection along the way. And sometimes retesting, I'm sure that Dr. Pasterla and Dr. Boyle have countless situations where a retest identified a positive infection, and everybody was pretty darn happy that they held the line and said, no, we need to get more samples and wait before we release this horse.
Yeah, 100%. There's so many day-to-day things we do around a barn, right? That we just take for granted, where it's nose rags and you drop it on the tack trunk and it's just, but when you think of it in light of a potential Strangles outbreak, everything is a factor. And our own clothes and good old-fashioned soap and water, folks, and even a lot of hand sanitizers and things like that. There's small things, and there's also a little bit more complicated things that need to be taken into consideration in this, so we don't.
It's shocking to how much cross-contamination can happen just as a product of just normal barn operations. And I would feel remiss right now if I didn't put in a plug for Dr. Katie Flanham Youssef, who's a biosecurity queen, and burn the nose rags. The nose rags are the bane of biosecurity's existence. And so we should not be, and I love her, she always has this analogy. We don't share tissues between people. I wouldn't blow my nose and hand it to you. I might hand it to Nicola, but certainly not Ashley. And so we shouldn't be sharing snot rags between horses. It's gross. And similarly, communal water troughs at public places. We know that water is a great, it can harbor Strep equi, those the big water troughs. And certainly horses may share water sources at home in their own small paddocks and herds within a close population, but you wouldn't go to a concert and share a lemonade with everybody around you. So we probably can apply some of those. We should apply some of those principles when we're out in public with our horses.
Yeah, 100%. I love those analogies, and they definitely bring the ick factor. So it's something to think about, folks, with our horses, just as ourselves.
Nicola, you need a tissue?
Well, no, but the nose rags are great. You want to burn them? I say no, don't burn them. Test them. Imagine if you have a nose rag that you restrict your single horse. Maybe you keep it in a Ziploc bag, and you can do the same when you're trying to screen the silent carrier. You can collect. It's interesting. The nose causes active secretions, but it's also dried off secretion. So if you can capture the two, even better. And if you can even exercise the horse before you collect that sample, exercise will actually increase respiratory secretion due to the increased volume of air that's brought in. If you're a runner, you realize that, the first mile, you're going to be hacking and coughing and spitting a lot. Very similar to horses. So don't burn them, use them amongst different horses. But maybe maybe that's one way we could find a relatively easy fashion to collect over time sample to determine if a horse is a silent carrier or not. And it doesn't need to be a nose rack. It can be, there's other individual little that we can use that will work. But it's, there's a lot. I think education is essential. I feel like when it comes to strangles and outbreak, everybody's pointing the finger to, you're the veterinarian, you fix it, rather than saying, no, we are all part of this. So if everybody does its part, from a little bit of biosecurity to monitoring to diagnostic specific biological sample, when it comes to, that's the role of the veterinarians, we would be better off. So there's really a lack of ownership when it comes to prevention, which on the other side is, as I say, it's a job for me, but it's sometimes very frustrating when you're the person that has to fix the problem, a problem that did arise because people really didn't pay attention.
Absolutely. So our theme is test early and often. But no, 100%. I think when all of us have a little bit more diligence and responsibility, we can prevent a lot of things like this from ballooning out of control. So I think that's a really good sentiment. And I know all of you consider this, on the daily, in your daily lives and your expertise. And at Platinum, we think about it a lot too, which is supporting the immune system, on a daily basis in horses. Healthier horses are always, better off with what they encounter. But in circumstances like this too, and I think, something that we think about is, we use Platinum Immune Support here, obviously, but the vitamin C factor is something to be considered too with this, because supporting those neutrophils in particular. And I feel like what's interesting about neutrophils is that when they ingest bacteria, then they release ROS, or reactive oxygen species, to kill bacteria. And neutrophils have, I think it's 50 times the vitamin C that what's circulating in the bloodstream. So they concentrate it and they use these stores to combat infection, which will then deplete those stores. So those bacteria-killing neutrophils can benefit from something like added vitamin C support, which is obviously, we're not talking antibiotics, or vaccines, but an additional tool that could be potentially beneficial to support a horse's natural immune system is something that, we always like to consider. And as we start to kind of close out our discussion, which this has been absolutely amazing, I want to kind of leave us with a last word from each of you. So what do you want those watching or listening to come away from this conversation with? And what would you recommend they do in their barn, on their property, with their clients, if Strangles is suspected or diagnosed? So Dr. Pasterla, let's let you have your last word, sir.
Absolutely. I would say Strangles is frustrating, but you can run away from it. Am I right? So I feel like a lot of veterinarians feel overwhelmed by the fact that they have to deal with an outbreak. And I always say, reach out. You're not alone in this. There's plenty of resources. Reach out to people that deal with this condition, to colleagues that have a lot of experience in the field. There's things that work, things that don't work. You can reach out to key opinion leaders, Dr. Denota, Dr. Ashley. You can call me, you can email me if you have questions about diagnostics. There's always willingness to help. We know as much as else. We just are fortunate because we're in contact with so many people. We get a lot of anecdotal stories we know from our own experience, but also from the experience of others. So what I always tell people is, if you don't know, just reach out. Nobody's going to say no. We're all here to help each other and hopefully over time find ways to get a better grip on this, very frustrating, as you said, very frustrating disease.
100%. Dr. Boyle, how about you?
Yeah. So a couple of things that I would think about would be related to what Dr. Donata said about the water, that moist environment really does encourage the bacteria to stick around. And so not only, the communal water places in public shouldn't be used, but when you have an outbreak on the farm, think about whether, like, when you're doing your separation of separating groups, think about where their water source is coming from, because sometimes two pastures actually share the same water trough, because it's on both sides of the fence, and so you may have one paddock that actually has the disease, and ideally you don't want them touching noses either, but you would want to clean that water trough regularly, and think about the fact that it may actually transmit through the water as well, through the water trough that way. And then another common thing that sometimes I hear people say is, well, it's here, everyone's exposed already. Like, I don't, it's too hard to separate them. But it really, again, back to the fact that if they have not actually come down with this disease yet, you do have a little bit of time when that fever is diagnosed to when they start shedding. And so you can actually then move that febrile horse into the infected group or an infected area, to try to limit the spread of the disease on the farm. So I would not, succumb to the disease and say, everyone's going to get it. We don't want everyone to get it, and it can, take some diligence, but it can be controlled within a farm if you separate and take those temperatures.
It's not a foregone conclusion. Sanitization, be careful, move those horses. Okay, I love it. I think those are all great pieces of advice. Dr. Donata, how about you to round us out?
I think that my advice would just be for those, if you have a farm or a property with horses, really focusing your attention very seriously on preventing it from getting onto your property is where you should double down and put your energy. And there's really, Strangles doesn't fall out of the sky, at least not that I know of. Not recently, at least. It comes in the form of infected horses, and there's two very classic scenarios that we see over and over and over again as clinicians. Somebody bought a horse from an unknown source and brought it onto the property and didn't do the 3-week quarantine period that went with or without testing that we often recommend. And so introducing a new horse to your property is a big risk factor. Remembering that a silent carrier may not have a snotty nose or something that would be obvious. So be very careful doing that. Quarantine horses for 3 weeks. Trust me, 3 weeks quarantine is worth it to prevent introducing strangles into your barn population. And then the other scenario is horses that are traveling and commingling and meeting other strange horses, and then they bring it back to their farm. And so when you're traveling, treat all of the other horses as potential carriers. Don't share nose rags, buckets, and a lot of, today's show facilities, we don't need to have 20 horses lined up along one fence line, everybody touching noses. I mean, there are ways to use the facilities themselves or your trailers and just try to maintain some sort of a protective barrier to be cognizant of the potential risks. And that's good. It's not just good for strangles, it's good for influenza and herpes and all the other things that they can be susceptible to. And if owners are able to prevent the infection from getting into their horses and onto their facilities, then all of the unpleasant discussion information we provided today about testing and quarantine and shutdown, that's all just superfluous information. You won't need to know it because your horse won't have strangles.
And isn't that just the best case scenario? So 100%. And there it is, ladies and gentlemen, a start to finish look at strangles. from 3 expert veterinarians and researchers in the field. And I want to thank each of you for being here to lend your expertise today. Who knew that talking strangles could be such a good time? And burn those nose rags. If we come away with any from this talk, burn the nose rags. But no, thank you to Dr. Pasterla, Dr. Donata, and Dr. Boyle for being here to lend their expertise on this very complex discussion and, gosh, a scenario and a disease state that none of us really want to deal with. So, and our thanks to all of you watching and listening for learning alongside me today. And I hope you join us for the next one. But until then, I'm Jessie Bengoa. Take care, all.